We are all set now.
Yeah.
Welcome to this session on importance of fluid management in wet AMD and real-world experience of brolucizumab, which is sponsored by Novartis. I have an esteemed panelist, Dr. Giridhar, Dr. Vishali Gupta, Dr. Parveen Sen, Colonel Mishra, and Dr. Dipendra Singh. Without spending any more time, I'll invite Dr. Gopal Pillai to give the first talk on demystifying fluid and brolucizumab real-world experience. Over to you, Gopal.
Thank you very much, Raja. Fluid is everything in AMD, right? So AMD in India is actually picking up because our old age people are also increasing, the prevalence of about 4% to 12% based on different studies. Early AMD, there's about 20%, and late AMD, almost 2.25 to 2.3%. Now we'll look through relevance of fluid. So what are the fluids that we have? One is intraretinal fluid, which is there in the red, then the subretinal fluid, which is there in the green, and then there's a pigment epithelial detachment. Below the pigment epithelial detachment is a sub-RPE fluid. So accumulation of retinal fluid is an indication of activity, and activity means treatment and retreatments. Now, fluid is a component of neovascular AMD, and this is a CAT study, about 1,000 subjects, which actually showed 80% of patients had subretinal fluid, about 3/4 of them had intraretinal fluid, and about 50% of them had sub-RPE fluid at baseline. So this is the initial thing. So subretinal fluid was the most common, and sub-RPE fluid was seen in about half the patients. Now, retinal fluid plays a critical role in every stage of neovascular AMD progression. In diagnosis, i.e. intraretinal as well as subretinal fluid are leading diagnostic criteria. So if there is large amount of fluid, time to first treatment is shorter, like we need to treat them as early as possible. And as I said, it is a marker of disease activity, which means that if there is fluid, when on treatment, you require to retreat. And visual outcomes depend a lot on fluid, as we will see later on in our slides. And treatment interval also, as the fluid-free intervals are there, we can actually treat them with a lesser frequency. But if there's fluid recurrence, you will require frequent recurrent treatment. So guidelines from the Europe, the Royal College of Ophthalmology, as well as American Academy, all of them basically talk about subretinal fluid or intraretinal fluid or any fluid or maybe quantity of fluid, etc. So, but they all talk about fluid whenever we we look at retreatment strategies. Now, in the real world also, where the number of injections are much less as compared to the clinical trial scenario, actually fluid drives the retreatment. Like these are the blue is the injection visits, and the gray is the non-injection visits. You can see there's a very high percentage of injection visits whenever there is intraretinal fluid or subretinal fluid as compared to the non-injection visits. So it's like this is the driver for re-injection. Now let us look at which of the retinal fluids among the three is more important. Now, there could be, whenever there is an intraretinal fluid or cyst, you can have a degenerative cyst or an exudative cyst. If there is a degenerative cyst, which are quite large, poorer visual acuity at, if it present at week 12, and the magnitude of effect is about 3 lines. If it is an exudative intraretinal fluid, if it is present at baseline, the visual acuity is poorer, and poorer visual acuity gains if it is present at baseline. And if there is a horizontal extension of the intraretinal exudative fluid, it correlates well with the visual acuity level. Subretinal fluid, on the other hand, better initial visual acuity will be there if it is present at baseline, but it is associated with higher retreatment needs. And pigment epithelial detachment, if there is large pigment epithelial detachments, there will be poorer visual gains if it is present in the baseline, and risk factor for progressive visual loss for these dosing. So if baseline intraretinal fluid is there is a negative impact on the best corrected visual acuity. And if there is residual or new intraretinal fluid or cysts which are present, worse visual acuity outcomes. Subretinal fluid, I said that baseline and residual SRF may have a little more better visual outcomes. And studies where SRF was tolerated, the vision trial, the fluid trial was basically, we're talking about that. The sub-RPE fluid, limited studies show the importance of sub-RPE fluid in neovascular AMD progression. Now, what is the long-term impact? Like, these are patients who have been treated, and at the 8th month, if there is no fluid versus if there is fluid, there's a significant difference in terms of visual acuity of about 8 to 10 letters. So presence of fluid leads to visual acuity decline. Now, what are the fluid subtypes and the impact of these? Now, intraretinal fluid. So if it is present, as I said, if it is present, we have a negative impact on visual acuity, but the location is also important. If it is subfoveally located intraretinal fluid, then it amounts to about 10 letters of decline in vision as compared to extrafoveal location, which is quite understandable. So if there is IRF at the foveal center, definitely visual acuity is a little worse. Now this looks at 12 months of data, and you can see that the white here tells us about the visual gain, and the dark blue here talks us about the visual loss of about more than 10 letters. So here you can see that by the 12 months, if there is no intraretinal cysts or fluid, there are about 35% of patients who have gain in vision, as opposed to only 3% with intraretinal fluid. There's a huge difference. And if you look here, can you see my yeah. So if you look here also, at 12 months, the drop in visual acuity is proportional to whether there is an intraretinal cyst at 12 months. So if there is an intraretinal cyst or fluid at the end of 12 months, there's a 55% people who have actually lost vision as compared to no fluid. There's a significant difference here. Now, what about SRF? It's the same type of graph. You can see the white here is the improvement of visual acuity, and the dark blue here is the loss of visual acuity. So presence of SRF by the 12th month, there is no significant difference here, 21 versus 30. There's a little bit of a difference only. Whereas loss of visual acuity, if the persistence of SRF, even with treatment, tells that there are about 40% of patients who lost visual acuity if there is persistence of SRF, as opposed to about 25% of patients. So intraretinal fluid here was more significant in terms of visual acuity improvement if it is not there, or visual acuity loss if it is there, as compared to the subretinal fluid. Subretinal fluid also, if it is persistent till month 12, there is significantly a chance of loss of vision, or if it is not there, there is an improved chance of increase in vision. Now, unresolved subretinal fluid leads to intraretinal fluid. In the fluid study, we try to tolerate about 100 microns of fluid, and as we tolerated, as we reached month 24, you can see that the the relaxed treatment arm had about double the intraretinal fluid as compared to the strict treatment arm. So strict treatment arm did not tolerate any fluid at all, and the relaxed treatment arm tolerated up till about 100 microns of fluid. So you can see that intraretinal fluid increase occurred in the second group. Absence of intraretinal fluid or subretinal fluid leads to better visual acuity, and this is more than 2 months of absence of intraretinal fluid, in which 5-letter gain is there. If there is less than 2 months intraretinal fluid or subretinal fluid are absent, then you have a 2-letter gain. So if this is the 3-month another biomarker, quantitative biomarker, sub-RP area or sub-RP volume. So if the area or volume is significantly low, there is less chance of recurrence. Whereas if it is high, there is a high chance of recurrence over the next few months. That is also significant. Now, this is sub-RPE fluid. You can see that the visual gains are not so much different at 12 months, even if there is sub-RPE fluid or not. But if there is sub-RPE fluid at 12th month, actually there is a loss of about 50%, loss of about 10 lines, 10 letters in about 50% of patients. That's very significant as compared to 20% only in the other group. Now, as you know, we are being replaced slowly by deep learning and artificial intelligence. And you can see that these are the fluid, which is manually picked up versus AI picked up, automated picking up. So you can see that activity, it's almost same. So AI or deep learning based, decision to treat or not to treat is going to be coming up in the next few years. Now, this is about high disease activity and low disease activity and how these fluid is there. So this is the 25% of patients who had the highest activity, okay, highest mean intraretinal fluid, 12 versus, higher 10. And in the rest, you can see that it's only 0.4 and 0.3. So you can see the difference between the upper 25% and the remaining 75%. Like that, high SRF, this is the value, whereas you can see it is very, very low here. So the high disease activity patients, again here also high PED, about 420 microns, 440 microns. Here you can see 25 microns. That is the difference in high disease activity versus low disease activity. So these are all automated or AI based algorithm to find out that IRF, SRF and PED volumes are all relevant for visual acuity outcomes in Hawk as well as the Harrier. Lower level of any fluid was associated with better visual acuity outcomes, and IRF or recurrent SRF and PED were associated with progressive vision loss. Now let us look at whether fluctuations in thickness or fluid will have any any functional visual disturbance. Okay, now they divide it into different quartiles, 1, 2, 3, and 4, depending upon how many microns of fluid variation was there. And as you can see, lesser the fluid variation, like the first quartile, you can see this is the 10 letter improvement as compared to 2 letter improvement in the other. Okay, now less CST variability led to also fewer visits. And in summary, all retinal fluid is considered a disease. Okay, and we require to treat fluid quite well. Thank you.
Thank you, Gopal, for the very nice presentation, some new insights which you gave. So I have a question for you. Do you follow the fluid study guidelines and tolerate any SRF, let's say beyond the first year? I know many people are aggressive in the first 6 months at least, but do you ever tolerate any SRF in some patients?
Generally, the idea, as you said, in the first year will be to not tolerate any fluid. But now with continuous injections, if there is still a little bit of fluid, maybe 50 microns of fluid, I may consider 50 microns to be observing. But
Okay.
in those patients also, maybe I will give them a 3 or 4 monthly injections.
Okay, because in one of your sessions in the morning, there was a nice case which was presented who was dry and then the vision went down and then the fluid came back, the vision
Yes.
improved. And that was probably less than 100 microns of fluid, which I had noted in your case. And I would just like to tell the audience here that at least in the survey of VRSI, which we did last year, 50% of the members actually tolerate some amount of SRF. But again, it's more debatable how much, what should be the location. Some people consider extrafoveal SRF as tolerable. I would like to ask a question to Dr. Parveen Sen. Dr. Parveen, do you look at the fluctuation of fluid on OCT? What Gopal very nicely brought out at the end, that more the fluctuation, more is the vision gain, or less is the vision gain that they have. But how do we control that? I mean, I don't know if it's in our hands, but do you consider that if there is more fluctuation, you would consider treatment more often, like monthly? How do you use that information?
I think I agree with what Dr. Gopal said, and the general consensus that, and the presence of fluctuating fluid generally means it's a disease which is not well controlled. So you keep on increasing the disease interval means there will be more fluctuation. So I think at this point of time, definitely a little loading dose or 2, 3, 4 monthly injections will be necessary. And tolerating fluid means that after you have given the enough amount of injection and still the fluid is not going, then you tolerate. It does not mean that the patient is having a drop in vision and the fluid is increasing, but it is 100 micron only. then you tolerate. But I will not tolerate 100 micron if it is a new incident fluid, that last month it was not there and this month it is there on OCT, then I think I will not tolerate that fluid. But if earlier it was 200 and now it is 100 and it is maintaining at 100 and the visual acuity is maintained, probably then, and already you have given lots of injections, probably then you will tolerate. Fluctuation for me means it is disease is not yet stable. So
Yeah.
I would definitely try to treat
Yeah,
more aggressively.
that's an important point you made, Dr. Parveen. One
May
thing
I,
I would
may I
like,
put one more point,
yeah,
Raju?
go ahead.
Yeah, so what I wanted to say that the study that I presented is based on monthly injections, where there was no role for us to play. It was like monthly injections. Whereas we in our real life don't do that for a year or two. We will do after 3 loading doses, we will go to PRN. And probably our duration between injections definitely increase. And that is why fluctuations can come in. So when they do monthly injections or very tight monitoring in a clinical trial situation, and then when fluid is fluctuating, that shows that activity is significantly high in those patients. Whereas in our case, when we are treating real life patients, it may be because we are, pushing the injections a little too far.
Yeah, so I think in the interest of time, we have to move on. There are so many things. I am sure everyone will have their opinion. But one thing, what Gopal has opened up is a very important point about how we follow up. These recommendations of fluid, of tolerating fluid, is from treat and extend regimens. They don't tolerate at any time. Even if the macula is dry, you treat them. It's just a question of following the extension, even if you have a little bit of fluid, but you still inject those patients, whether or not there is fluid. So we'll now move on to our next speaker, Dr. Subhendu Boral, who will be presenting his experience on brolucizumab. Over to you, Subhendu. We can't hear you, Subhendu. We can see your slides. You have to, I don't know.
Shubhendu, unmute.
Unmute. He's unable to unmute, it looks like. Can we unmute?
Yeah.
Whether it is audible?
Yes.
Yes.
So thank you, AIOS, for arranging this kind, and Omnovat is also for arranging this kind of beautiful webinar for this our experience with this new drug. So my real world experience is quite interesting. Like before 2005, there was hardly any choice of any anti-VEGF, but after that, pegatinoxonium, ranibizumab, followed by bevacizumab, aflibercept, aflibercept, combercept, and nowadays it is brolucizumab came up. And if you compare all these drugs, you can see the number of molecules per injection fixed volume. It is actually very much interesting. Like 0.5 molecules number of in the fixed volume, it is comparable to 11 molecules in that fixed volume with brolucizumab. If you compare ranibizumab and brolucizumab, accordingly, aflibercept 1 molecule can be comparable to 11 molecules of ranibizumab. So how we retina specialists are going to capitalize these new features of this new drug, that is a structural uniqueness, because it is a single chain antibody fragment that is the smallest functional unit of the antibody. It allows delivery of a greater molar dose compared to the larger volume. 1 molecule of aflibercept equivalent to 0.5 molecule of ranibizumab, which is equivalent to 11 to 13 molecules of brolucizumab. So it allows the faster penetration into the retina and the potential for more tissue penetration within first 1 to 6 hours. And for the, you should know that for ranibizumab, it is 6 to 12 hours, and for aflibercept, it's almost like 24 hours. So it allows faster penetration, and as well as if more drug will be accumulated into sub-RP and sub-neurosync retinal space, where the culprit CNVM is there. So it is responsible for a longer time. It is responsible for the increased duration of action, as well as for the extended dosage regime. So how we can assess its effectiveness? It is the interretinal sister changes, sub-RP fluid and sub-retinal fluid. That Dr. Gopal was telling, SRF is the most important parameter for the high disease activity. So coming to my experience, case one, a patient came in 2015 September, where he came with the subfoveal hemorrhage, which was 6 by 12 parts. There was distorted vision. I advised him DFA and OCT basic test. He didn't turn up. He came after 5 years, September 2020, where the subfoveal hemorrhage has gone up, and you can see the PED and OCT, and there is a little bit of fogginess in the right eye in the fovea. So vision came down to 6/12 parts. So I advised him ranibizumab. He didn't turn up. He turned up after 1 month. In the month of October, at that time, the fluid was persisting. I advised him at least you should take one anti-VEGF, ranibizumab, aflibercept, brolucizumab, whatever you want, whatever you search. And it was a treatment naive patient, and left eye was absolutely normal. He took the brolucizumab. So fortunately, it was my maiden patient, and he took the brolucizumab. And after 5 weeks of brolucizumab injection, the PED was persisting. The blockiness of the overlying neurosocial has gone down, and vision improved to 6/9 parts. And after 11 weeks also, you can see the vision improved to 6/9. And after 20 weeks also, this was maintaining to 6/9. The blockiness of the neurosocial was not recurring. And after 24 weeks, there was recurrence of SRF, and you can see the sister changes came. And after giving this second injection, the vision improved to again 6/9 and at the 30 weeks plus. So coming to my second case, it was a case of stable diabetic 80 years old male, and where there was a lot of sister changes. You can see there in the OCT, and there was sufferers of macular hemorrhage and occult CNVM. PED was there after 6 injection of ranibizumab and 2 aflibercept in the left eye. The sister changes are totally almost resolved, and PED part is significantly reduced. And after in September 2020, the vision was stabilized to 6/18 parts. But he again came in the month of October 2020, where the vision dropped down to 6/24 parts, and there was recurrence of CME and as well as PED part. So left eye was absolutely normal. After 2 weeks was normal, means there was a little bit dilated choroidal vessels in the OCT, but otherwise sister changes at SRF was not there in the left eye. After 2 weeks of giving this 6 mg brolucizumab, you can see the sister changes is totally resolved, and PED part also resolving, and there is a lot of fuzziness at the junction of neurosocial retina and the PED. So there is showing some kind of regression, vision improved to 6/18. Now again, after 6 weeks of giving injection, this margin, this junction margin is more well demarcated. That means more scar formation was happening, and 6/18 vision was maintaining to 6/18. After 16 weeks also, there was no recurrence of fluid or SRF, or even after 24 weeks, it was doing very fine. This macula seems to be absolutely dry in stage, but at 28 weeks, there was a recurrence of slight SRF was coming, and the PED pulse was also, it is elevating. So after I have advised him for second dose, and after second dose at 32 weeks, again the SRF and the minimal SRF as well as the PED pulse shows some kind of regression. So coming to the third case, it is a vitrectomized eye. I did the vitrectomy for the subfoveal hemorrhage, at vitreous hemorrhage, but there is a lot of scar in the macular area. So before injection, the vision dropped down to 3/60 from 3/60, and you can see the sister changes in the neurosocial retina, but no SRF. So I have advised him brolucizumab, and after 2 weeks of this injection, the sister changes was also it's totally resolved, but the lumpy macular area, the scar formation, it is not showing any kind of regression. Vision improved to 6/60. Coming to my fourth case, this is a bilateral case, stable CNVM after repeated injection of anti-VEGF, vision was 6/18 and 6/12%. But in the month of December 2020, there was recurrence of SRF and PED in the left eye. You can see the vision dropped down to 6/18 and 6/12 in the left eye. And after 3 weeks of giving this brolucizumab injection, the SRF is totally resolved, and as well as the PED, you can see that in the left eye, PED part is almost, it is both height and width of the PED is totally almost regressed, and small thumb-like elevation was there. But coming to my case 5, where there was recurrent CNVM, and I advised brolucizumab in this case from 6/18, vision dropped down from the 6/9 parts. And after 2 or 3 weeks of giving this injection, you can see the SRF is totally resolved, and although the PED part was still persisting, you can see the OCTA picture where there is hardly showing any kind of signs of CNVM. And coming to my sixth case, where you can see the left eye was, it was a case of stable CNVM, vision was maintaining 6/9, and there was PED part was there, but no SRF, but there was recurrence in the month of January 21, and vision dropped down to 6/9 parts, and that's the PED parts almost resolved after 2 weeks of giving the brolucizumab, vision stabilized to 6/9. And this was maintaining after 6 weeks of this bolucizumab injection. Left eye was showing some kind of thumb-like elevation, but no SRF, no interretinal sister changes. I have not touched that eye. So coming to my 7th case, where it is the case
Sorry to
of
interrupt, sir,
recurrence.
but the time is up. You need to conclude. I'm really sorry for this.
Out of time, we have to give the horse.
And it's a case of after 2 weeks of giving this injection, the SRF sister changes was totally resolved. And coming to my 8th case, you can see there was left eye rear surgery done for hemorrhagic retinal detachment. Right eye was showing a lot of old scar, and you can see the solid PED. Slight SRF was there. Sister changes was there after giving this injection 3 weeks. You can see that it's totally resolved, although the solid PED was still persisting. So coming to my 9th case, there was SRF recurrent CNVM. So I advised
Sir,
injection. Yes.
Sir, your time is up. We can't see your slides at all.
Okay.
Yeah, can you conclude, Subhendu?
Yes. So till now I have given 51 injection in our hospital. It is 248 injection total. Most of them are PCV or AMD, not not in any case of DME or BRVO. So touchwood, no adverse reaction I faced. So we should have some kind of special consideration, as it is a new drug. We should use it judiciously, avoiding one-eyed patient. We should take the proper consent and frequent follow-up, especially 1 week or 2 week follow-up is required. Thank you.
So thank you very much, Subhendu, for those excellent cases. You have a big series actually, but in the interest of time, we will take questions only at the end if they have any time. I now request the next speaker, Dr. Upsham Goel, to share his cases. Over to you, Dr. Goel. Can you stop sharing, Subhendu, so that the next speaker can upload?
I think I stopped sharing.
You have to unmute.
Yeah, fine. Am I good now?
Yes, we can hear you.
Thank you. Sorry for the delay. So, like all the previous speakers have already spoken, this is a very, very exciting new drug. And let's straight away go to what is something that we have seen. Of course, this is the usual disclaimer and we all, I will not go through the introduction. We already have gone through that. The important thing is the point which we are trying to make here is that, so we have this here. So this is what we have. That there's a lesser time required to penetrate the retina because this is just 26 kilodaltons. Besides the other pharmacological differences that this drug has over others, and therefore the half-life can also be longer, and it can penetrate deeper in between these spaces, which the other larger molecules cannot. So this was the study, which was the Hawk and Harrier trial. We are all aware that the Hawk trial had 2 doses of 3 milligrams as well as 6 milligrams. So what was found was that 3 milligram is very effective, but 6 milligram on 12-week dosing, 6 milligram on 12-week dosing was as good as 8-week dosing of aflibercept. And you can see that the best corrected visual acuity was similar, and the proportions of eyes with persistent intraretinal fluid, the significance of which has already been spoken about, is here. So there is less intraretinal fluid with the 6 milligram. 3 milligram is also doing a good job, but in the Harrier trial, we had 6 milligram of rolizumab, which showed that the intraretinal fluid that it can decrease is less than aflibercept does in 8 weeks. So these are some of the patients I'll just show you. This was a gentleman who had already been injected rizumab 5 times, and despite that, he had a huge PED. And then we gave 3 more injections of ranibizumab, and finally, this was the appearance. After 5 times, this was the appearance. and this was the OCT. 5 doses of Rizumab, and then again we gave additional 3 doses here. And so this is the end result after 5 plus 3, 8 doses of ranibizumab. Finally, we shifted to brolucizumab, and look at this. Just 1 month after this, this is the kind of resolution we got. And then after the 2 doses of brolucizumab, almost a normal looking OCT. Similarly, patient 2, he had some fine lesions here in this region. And you can see the massive neovascular network forming in this region here. Right here, you can see, right? And you can see in the OCT also here. And this is just 1 month after this. Look at the massive resolution of all the neovascular net that was happening. Then another patient, best corrected visual acuity of 636. And the patient was straight away put on brolucizumab on 14. This was the appearance of the neovascular net here. You can see this is a 6x6 angio-OCT. You can see the neovascular net here, and on the cross-sectional analysis, this is the situation. And so on 11th, we saw this patient, and on 14th, we gave the first shot. Just 3 weeks later, this is a 3x3. The previous one was a 6x6 OCT. This is a 3x3 scan, so it is more kind of zoomed in. And you can see that after the first dose itself, very significant resolution has taken place. So we continued the treatment up to 3 injections, and then we found that this was the stable situation, and it was neither improving beyond that nor getting any worse. As patient 4, this was SRF with scarring, and this is the scar we had here, and you can see the cross section along with the scar tissue. There was significant amount of fluid, and we gave the brolucizumab, and this is the result after that. Patient 5. We have best corrected visual acuity of 648, first shot of brolucizumab given. This is the image. Look at this net, massive net here. And after the very first shot, this is the level of resolution we were able to get. Now, what I'm trying to say is that the resolution that we are getting with this drug is something I've never seen. I've been using Avastin from 2008, that we were among the first to start Avastin, VEGF in private. But this kind of resolution is amazing. So what the conclusion in short is that it is a very potent intravitreal anti-VEGF, and 6 milligram is definitely is better than 3 milligram, but 3 milligram is also very effective. And like we have the other studies, like the Marina studies and all, which talk about side effects, which is beyond the scope of my discussion right now. But like the previous speaker has said, that we need to use it judiciously and with care. And once in 3 months dosing seems to be quite fine. It seems to, even the loading dose, we could probably change from once a month to once in 2 months to begin with. Thank you.
Thank you very much, Dr. Goyal, for finishing on time. I'll have one quick question to Dr. Vishali. So, Dr. Vishali, would you recommend monthly loading doses in these? While it is recommended in your practice, do you think there is a role, given that also that right now there has been a recommendation not to give Q4 at least after the loading dose, but do you follow loading dose at the beginning?
To be very honest, I don't have this much experience to compare the loading versus non-loading dose, but a couple of patients where we have given the loading doses.
Okay, good. So in the interest of time, we will come back to similar questions later on for discussion, but we'll move on to the next case. And now I invite Dr. Ashish Vaidya to share his cases. Dr. Ashish?
Yeah. Yeah, is my slide visible? Raja?
Starting, yeah, it's visible now.
Okay. At the outset, I would like to thank AIOS and Novartis for inviting me here. So today I'm going to discuss a couple of cases of brolucizumab in wet AMD. This was Mrs. ABC, age 75 years. She had reduced vision in the left eye since 2 weeks, and vision in the left eye was 624 N12, PCI in both eyes, no history of diabetes or blood pressure. And here you can see this was a OCT done elsewhere. She did not want to repeat it. And you can see that in the left eye, there is a large PED along with subretinal, intraretinal, and sub-RPE fluid. Here you can see the presence of some amount of SREM also. And she received brolucizumab in October 1st or second week of October 2020. We explained everything to her, told her about the reactions, and the reason she wanted to take up brolucizumab because her daughter was in the US, and she wants, after the first 3 loading doses, she felt that she could come to the US for about 3 months and not worry about taking another dose. So we gave her the first dose, and on the first day there was nothing. On the second day, you can see over here that the vision was 624. There was no inflammation. However, I noticed that there were 2 small hemorrhages over here. They were very subtle and tiny hemorrhages. And when we went back to the picture over here, you can see that those 2 hemorrhages are here also. So it's very important to have a detailed color photograph of the patient, because in case reaction happens, in case vasculitis happens, we need to compare it with the picture which has been taken pre, and this helps in detecting subtle cases of hemorrhages. So we gave the second dose of brolucizumab, and again the intraretinal fluid subsided, the PED subsided. In December 2020, the vision subsided, the PED subsided still more, and after 3 loading doses of brolucizumab, the patient's vision was 6/9 N8, and the PED was almost flattened, and she went to US on a happy note. Now that doesn't end the story over here, because we were thinking she was in US. At some time she came back, and then she had COVID, and then she never followed up. So the moral of the story is that whatever anti-VEGF you do, the patient has to follow up. So patient came straight back in June 2021, and she came with a vision from 6/9 N8. The vision has now dropped to 660 N36 with a subretinal fluid over here, a hemorrhage over here, and here you can see a very bad result. So we have again started with the brolucizumab. Maybe we'll give a monthly dose of brolucizumab again and see how the result is. The next patient is Dr. VS. He had a right eye macular scar due to wet age-related macular degeneration. Left eye drusen, vision 6/9 N6, and he was followed up consecutively in 2013, 2014, and 2015. In 2016, he developed wet AMD. At that time, he was given 3 injections of ranibizumab, and here you can see that this significantly worsened. He was then shifted to aflibercept and given aflibercept on a treat and extend basis, but even then, he could never manage to go beyond 6 weeks. At the most, we could go up to 7 weeks with this. And here the subretinal fluid was persistent throughout. And he was maintained on aflibercept in 2017. This is 2018 picture, 2019 picture. And then we got brolucizumab in 2020. So we gave him brolucizumab, and for the first time in the last 3 or 4 years, there was no subretinal fluid. So here you can see the magic of brolucizumab, that the subretinal fluid which was there in all these slides has now for the first time gone off. Patient's vision improved from, the near vision especially improved from about N/10 to N/8. And what he said was that he was a diabetic taking insulin, and for the first time in the past 4 years, he was able to see the markings of the insulin syringe. However, these are all COVID times, so we decided on the PRN right from day 1. And here you can see after about 2.5 months, you can see that a little bit of fluid has come up. So we again injected brolucizumab, then again a little bit of fluid came up, again injected brolucizumab, again the fluid came up. The patient was also very on irregular follow-up because of the COVID. And finally, in May 2021, we have seen him, again there was recurrent fluid because of a very active, very severely active disease, and we have given him the 5th injection of brolucizumab. Thank you.
Thank you, Dr. Ashish, for the nice presentation. So if I can ask Dr. Dipendra Singh, would you still consider giving, let's say in patients like the recurrence which you are seeing here in Dr. Ashish's case, Q4 weekly dosing of brolucizumab even beyond the loading dose? Do you think in spite of the safety recommendations, you would take the chances of let's say a hypothetical case requiring frequent injections at Q4 weeks?
No, I think I'll be little more cautious for Q4 dosing right now, especially seeing this, cautions being issued. But only thing what I would like to add here is we need to do further subgroup analysis of Hawk and Harrier and other studies to see that how long this molecule keeps on acting. See, Pronto did a very good job for us by doing daily and weekly OCTs, and it told us that even at 2 or 3 weeks, the drug is still acting. You get continuous reduction in subretinal fluid. So at 4 week, if I see fluid still there, I would like to see at 6 weeks and 8 weeks. And if they can come up with data which can show that the fluid can keep on reducing till 7-8 weeks, then there is no point repeating it that early. Especially I think for these recurrent patients, I would still hesitate because anyway they are not in the initial phase of disease, so their requirement for injection is not that high as the patients who are treatment naive. So I would hesitate to shift them on 4 weekly regime. But yes, 8 weekly is a good idea. I think one speaker suggested. I think that's a good idea.
Yeah, I think that also would help. Apart from the number of injections, even the frequency of visits becomes important.
Yes.
So that also reduces, and we will know, as you said, if we do further detailed studies of doing those OCTs more often, we will know when to call the patient again. I mean,
this one basically, I mean, in this patient which Ashish showed now, actually the intraretinal fluid disappeared with the first injection itself.
Yes.
And is there any need to give further injections immediately for the PED?
No, it was for the subretinal. This is Dr. Girdhar. The subretinal fluid came back. The patient himself is a one-eyed and he's a doctor. So, he picks up his decrease in vision immediately. And when he picks up his decrease in vision, he comes back to me and tells me that, okay, fine, I need an injection. See the OCT, I need an injection.
The patient who went to US.
Yeah, the patient who went to US, yes.
That patient, after your first injection,
correct,
the OCT scan that you showed
did not have intraretinal fluid. There was only sub-RPE fluid.
It was only sub-RPE fluid. So is it necessary to treat so aggressively the sub-RPE fluid is what I'm asking. I mean, the opinion of
that was October 5th of October. Brolucizumab had just come in and we were told to give a monthly loading dose. This was a treatment naive patient and it was the first time that she was receiving an anti-VEGF injection. And that is the reason why we gave a loading dose at that time. And if you saw over the period of the 3 months, the PED also has kept on flattening and the vision has kept on improving with every visit.
Because
so that also
sometimes what happens is that, see, the sub-RP fluid, it's not only sub-RP fluid, it is also sub-RP fibrovascular complex.
Definitely.
So sometimes what happens is that if we treat aggressively the PED, you may land up in atrophy. So because PED sometimes when they collapse or when they shrink, you also create an atrophy, especially in eyes where there is a pre-existing thin choroid. So I think that's an important message. So I mean, your case is very nice. I mean, it's very nice and it shows the recurrence also, which is very important. But I think aggressively treating PED sometimes can be a little, counterproductive.
Yeah, so I think Dr. Girdhar, you have brought out an important point. We need more data on treating sub-RP fluid, although Gopal Pillai's talk mentioned about sub-RP fluid reduction also having some improvement.
No, if it occurs spontaneously with the treatment of the subretinal fluid, it's a different issue.
Yeah.
But after complete resolution of the subretinal fluid, I think giving additional injections for the sub-RP fluid, I think we need to, have some criteria to decide when and what.
If I might add, the appearance of new sub-RPE fluid is extremely important because it indicates an underlying choroidal new vascular membrane. So if it is reappearing, then it should be given injection. It cannot be.
That's an important point. And that's where brolucizumab probably has an advantage, having more effect on the sub-RPE fluid. But again, we will go on to the next case and come back on these points for discussion later. I now invite Dr. Preetham Samant to give his experience. Over to you, Dr. Preetham.
Thank you, Dr. Raja. Again, thanks to AIOS and Novartis for having this forum. Can you see my slides?
Yes, yes.
Yeah. So, I was asked to present two cases because I think 6 minutes, they were suggested that I should, present two cases. So I've chosen two cases. One is a treatment naive patient and one is a patient whom we switched over from a previous anti-VEGF to brolucizumab. So first one is a treatment naive patient. Now this lady was bilaterally pseudophakic, came with a drop. Now she's been with me for a couple of years, this routine follow-up. So this was actually her in way back in 2019. She was fine, both eyes are multifocal IOI. But she comes to me in December of last year, 2020, with a drop in vision in the right eye and metamorphopsia. Now you can see over here a juxtafoveal CNVM, very evident clinically. She's a diabetic. You can see some background diabetic changes. Now, this is the OCT. Although this scan is going through the fovea, is showing some intraretinal fluid and subretinal fluid. The parafoveal scans clearly showed the neovascular complex. And I counseled her for loading dose of brolucizumab. That time brolucizumab had just been introduced and we were all looking forward to its results. So I counseled her for a loading dose like we used to do for the previous anti-VEGFs. And she took her first loading dose just then on 27th. I diagnosed it. 2 days later, she came and took her first injection. And then when I saw her a month later, on 2nd February, her vision had already bounced back to about 266 parts. And that day I gave her the second injection. This was a OCT on that day when she took her second injection. Just before the injection, you can see the the anatomy restored back to as if nothing had happened. This was a second injection, and on 16th March, she took her third injection as per we had decided. And then on 16th March, I told her, let's, to come back after about six weeks. I thought I will sort of go for the treat and extend kind of a protocol, which I'm more used to following. So she did come back on 3rd of May. Now on 3rd of May, she was maintaining 6/6 vision and her OCT was looking good. So at this time, I suggested instead of injecting at this time, if the anatomy is looking so good and she's fine, I thought I'll extend it by another 4 weeks. So I told her, we'll see you after a month, we'll do the OCT and then we'll take a call. Now, she calls me in the first week of June saying that she has COVID and she won't be able to obviously come, but she's fine. Symptomatically, she's fine. And till date, it's been almost Q14 since the third injection on 16th of March. And symptomatically, she's good. But I'm still waiting for her to come back. I don't have her latest. This is the last VAA and assessment I have, that is on 3rd of May, where she's 3 injections of brolucizumab and now she's 14 weeks. This is how it is, 3 injections of brolucizumab, and now today she will be 14 weeks from the last injection on 16th of March. So this was my first case, treatment naive patient. The second case, interesting scenario, because this lady actually is a NRI. She has been with me since, again, 2018. Now, actually there are 2 physicians treating her because a retinologist from USA, whom she has a lot of faith in, sort of helps me and dictates a lot of terms in suggesting the injections. So she was with me since 2018-19, and she's been taking a lot of aflibercept in her right eye and Avastin in her left eye for wet AMD. And I'll cut the story short. I'll start the story from August 2020 last year. Now, this was a situation that if you see in the right eye, we were dealing with a little activity here in this area. Rest of it is scarred. You can see the other eye which is scarred. And for this particular activity with OCTs, she required about 3 monthly aflibercept. So I gave her an aflibercept on 3rd of September. I had given her an aflibercept, and her vision was maintained at 636. In the left eye, it was 660. Now, I was expecting her to maintain, but on 19th November, a few days before that, she called me saying, look, my right eye, the good eye vision has suddenly gone down. And I called her over, and her vision had gone down to about 2 meters, counting fingers. She was definitely saying, now I can see better with my left eye. And when I saw, if you see the right eye, there are subretinal hemorrhages here, and there is some kind of an exudative response which is happening over here. Now, I was not able to take OCT scans to this, but there was definitely some exudative response and fluid, like in this particular area. So at this time, again, I said, let's, with consultation of a retinologist in USA, we decided to switch from aflibercept to brolucizumab, and she took her first brolucizumab on 19th of November. And one month later, in fact, few days before that, she called me saying that her right eye vision seems to be a little better, seems to be stabilizing. She came on 29 December, where her vision had come back to 636. Although the central OCT is more or less the same, but you can see this fluid here, which is a little supranasal to the fovea. Actually, you can see it's dry. That particular portion is dry. And then she took, and I was, although I was keen to do it in a PRN fashion, her retinologist in USA said, let's go with a loading dose. So she took her second dose on 3rd of Feb, and 3rd of Feb, everything seems to be dry. And this is, if you see how the exudative response has gone, it looks much more dry in this particular area. The hemorrhages seem to be a little less. Symptomatically, she's better. So this is how it was, this is how when we dealt with in November, and this is what it was when she finally took her third injection on 3rd of Feb. You can see this. This is how she has symptomatically improved, and clinically it looks better. So and now she has flown back to the US. So I don't know. I won't have any further follow-up from this patient. So these were the two cases I wanted to share. Thank you.
Thank you, Preetham. That were very, very interesting cases. So, Dr. Giridhar, would you like to comment on any of the?
Yeah, I mean, nice cases actually, Vishali. What I would like to know from the, from what I've understood now is that, as far as I'm concerned, I give brolucizumab on a PRN basis. I'm not giving it probably because I'm not treating it much on treatment naive patients, but mostly on patients who have already been on they are all switch treatment. The thing is that, but what I have seen now is that even on a monthly, one of the reasons why we are a little careful is the rare intraocular inflammation. So now from what I've seen is most of these doctors have been injecting it on a monthly basis. And in spite of that, I think there is hardly any incidence of any intraocular reaction. So I think that's an important take-home message, that basically the risk or the inflammatory reaction is there, but it's quite uncommon. So that's I think an important. I just want to know what's the panel's opinion as far as their opinion on this particular matter, because this is a very important issue, and this is one thing which is really acting as a stumbling block to use this drug more on a very wide basis in many patients, where we know that this drug probably is the ideal choice, but we are a little reluctant because of the possible like one-eyed patients, etc. So,
Dr. Giridhar, there has been a recent advisory after.
Yeah, I read that article. Yeah.
So the problem is that even though in the real world we may not be seeing inflammation, only thing is like my major concern would be like I would love to inject it every 4 weeks, but God forbid if one of my patient ends up with the occlusion or inflammation, would I be able to defend my action
Exactly.
in the recent thing by the company itself?
Exactly.
So that is something, I would like Dr. Dipendra and Dr. Praveen also to give their opinion.
Yeah, I agree with you, ma'am, and I think I agree with Dr. Giridhar also. So we have time and again seen that this drug is really working.
Yeah.
And we have seen that the intraocular inflammation is not too much, yet keeping this advisory in mind, I think we should not just write off the drug also. We need to use it judiciously. We need to keep sharing our experiences and keep learning from them. So slow and steady, cautiously going forward is the answer, I think.
Like instead of 4, maybe 6 weeks, what
Yes.
6 weeks of probably.
So that's what Dr. Subhendu's cases were really encouraging. And I think if I'm not mistaken, most of his cases, as well as one case which Dr. Preetham showed, they are PCV cases. So
Yes.
basic test for any anti-VEGF. Anti-VEGFs we know don't work too well where PCV is concerned, and showing good response in PCV cases can be really, really encouraging.
And last comment, Dipendra.
Cautiously and keep in mind what is happening.
Thank you.
I think
this is what I have also been recommending for long, that see, the concept of monthly dosing is totally arbitrary. It is not a scientific way. We knew in earlier VEGFs that the duration of the VEGF action used to last for 1 to 1.5 months. Therefore, it was prudent to use the loading dose on a monthly basis. But now with this drug, we know it works for beyond 2.5, it works even beyond 3 months. Therefore, the loading dose naturally needs to be changed to 1.5 to 2 months. This is what I've been recommending ever since I've been using brolucizumab for a long time.
The USP of this drug was the long interval between.
Exactly. Very true. And secondly, some of the cases which I also showed were again of PCV. The one which I showed with post 5 injections, then another 3 injections, after 8 injections of ranibizumab, immediate response. So, we need to rationalize. And what I do is I follow them on a monthly basis with OCT and OCT angio and see if there is an increasing fluid, then I will go ahead and treat rather than doing an arbitrary loading dose.
So I think Dr. Goyal showed some of the OCTAs where the neovascular net almost disappeared. And even in Dr.
And so
even in Dr. Preetham's first case of Dr. Preetham, if you see the new vessel is not to be seen, the CNV is not to be seen after the 3 loading doses.
Some of the I'm sorry to cut you. Some of the cases we have seen from other presenters, we have seen even a very prominent SREM also, getting disappeared after this injection. So I think everybody has made very right points that this is a drug which we have been waiting for, but it has brought some caution in the sense that there is a chances of both thrombotic or inflammatory kind of occlusions, which people are still trying to analyze whether it is immunogenic or the other etiology. But having said that, overall incidence is matching the incidence of infection. So whenever we are deciding about injections, we are anyway very cautious whether it is real life or trials. Good part in real life is you are not bound to give 4 weekly injections, and most of us are actually, even when we advise 4 weekly injections, our patients will anyway choose their appointments and dates. And we also have a flexibility of combining multiple anti-VEGFs. So at which phase of disease suddenly you get a CNVM which is becomes very aggressive after staying quiescent. You have a very good drug to back up even those cases. PCV going wrong direction. You all have seen sometimes PCV is quiet and suddenly it can change gears. So it's a wonderful drug, and I like the idea of Dr. Vaidya of clicking 7 field photographs of these patients. We are doing it in our setup just for the research interest, not that for any other reason, because that's again a very good idea, so that the moment your own data will convince you better than anything.
Thank you. Thank you.
Can I make one quick comment? Can I make one quick comment?
Maybe next, after the next talk, please. We go on to Dr. Anirudh Maiti. Is he around? Yeah, perfect.
Thank you, madam. My presentation is visible?
Yes.
Yes, it is.
Perfect. Yeah.
At the outset, I would like to thank AIOS and Novartis for giving me this opportunity. Well, I will be sharing my experience with this new molecule. Coming to the first case, 68-year-old male patient and medico himself had a blurring of vision since last 5 months, and the vision on the right eye was 660 and the left eye was finger counting to fit. In the dilated fundus examination showed that it was a case of a bilateral CNVM case, and as you can see in the OCT, this was the right eye, and the left eye you can say the shrimp-like structure. So What we counseled in the left eye, as it was not prognostically very good, so we advised him eccentrics in the left eye. In the right eye, he was given a choice of aflibercept or brolucizumab. And he being a medico, he actually decided for the newer molecule, going to the literature. And luckily, it was a very dramatic response. We got a very dramatic response after a month after giving the Peganex in the right eye. You can see the lesion has subsided, the size of the lesion has come down, and the vision has improved from 660 to 636. And the left eye, as we were discussing, it was not prognostically good. The fluid has definitely come down, but the vision was unchanged. And as there was a lot of discussion before this presentation, loading dose, to give loading dose or not, but actually we followed Hawk and Harrier, and we followed it was a treatment naive patient, so we followed the monthly loading dose. And this was the picture in the right eye after the second dose, and vision further improved to 624. We didn't give any injection in the other eye. And this is after the third dose. The patient actually did pretty well and was so happy. For the first time, the CMM patient was so happy. And the left eye, he actually insisted me to give one injection in the left eye. It didn't change much, but he was symptomatically better. So if I summarize this first case, treatment naive patient improved from 660 to 618 after the loading dose. Coming to the second case, this was a 56-year-old female patient, had a sudden dimness of vision for a week's time. Right eye had a subretinal bleed. Seeing the OCT, it was suspected to be a PCV bleed. That time in the COVID times, we are not going for the invasive test. And by this time, we had a little bit of experience on the Peganex. I decided for injection Peganex. And this patient was an outstation patient. So I actually called her for in the first week itself. In the first week, actually, it showed there was the reduction of the subretinal blood has started. And also the height of the PED has come down. And the vision improved from finger counting to 1/60. And this patient, when came after a month, it improved further to 660. And this patient also, we gave a loading dose. This is after the second dose. You can see the PED height has decreased and patient was symptomatically much better. And this is the summary of the second case, treatment naive, or most likely a PCV bleed, improved quite a lot. And the vision 636, we are waiting for the third month visit. Coming to the third case, this was a 62-year-old male patient, had a dimness of vision for 2 months. Left eye had an active CNVM or a PCV. We'll come to it why there was a query. This was a picture. This was in the month of June. And after 3 loading doses of eccentrics, it responded pretty good. And the vision improved to 618. But after the third dose follow-up, 6 weeks following that, there was a recurrence. And you can see there's a notched PED. So most likely it can happen as an PCV lesion. And this time we actually switched therapy from eccentrics to Peganex. It responded pretty well. This is after 4 weeks giving the first dose of Peganex. So this is the summary of the third case. Recurrence after 3 loading dose of eccentrics, responded well with Peganex. Fourth case, 64-year-old female patient. This was also bilateral CNVM. The right eye was scarred CNVM with SRF. The left eye had an active CNVM. The right eye, 1 dose of eccentrics was given, and the left eye, 3 doses of Eylea was given. This was at presentation, and this is after the loading dose of Eylea, which actually the vision improved to 612, and she was doing fine. We were doing a follow-up, and this happened exactly like the earlier case. After 6 weeks of the third dose follow-up, there was a recurrence, and the vision dropped down to 660. Now we switched to Peganex, and it responded pretty well. The vision improved to 612. And we were following every month, and at third month, to be specific, 11 weeks, the SRF had started coming in, and we gave the second dose. And the vision improved by 1 line. So this is the summary. This is after the second dose of Peganex, when there was a recurrence of the 3 doses of aflibercept. Coming to the last case, this was a 78-year-old male patient. Left eye had a scarred CNVM, and the right eye, the CNVM was responding to treatment, but there was a recurrence like 4 to 6 weeks. We had to give an injection of aflibercept. So this was the picture. The vision dropped to 618 after 7 doses of aflibercept. This was 6-week follow-up on the last injection of aflibercept. We decided to give brolucizumab, and it responded well with the improvement in vision. So this is the summary of the 5 cases. The first one was the treatment naive CNVM. Second one was a PCV bleed. This was also treatment naive. And the next 2 was recurrent CNVM post Lucentis and a recurrent CNVM post Eylea. And the last one was refractory CNVM. All the scenarios actually, the Peganax worked very well. This is the entire list of the Peganax which I have used till date. It's more than 50 patients and mostly CNVM and PCV. Few off-level indications of BRVO and DME. As far as the Indian experience goes, total number of procedures is already 3,000 plus. There is 19 IOI. Most of them are mild, responded with the steroids. Only one serious adverse effect, which has been already published in IGO. An indication used mostly are AMD and PCV and few off-level use of DME, BRVO and CRVO. So coming to the take-home message, with this new molecule actually showed a dramatic response in drying up the macula, whether it was a subretinal, interretinal, or a PED or a central macular thickness. And obviously there was
straight away to cases. A 60-year-old man has been under my follow-up since 7 years. Vision has always been fluctuating between 618 and 612. He notices a blur whenever the SRF increases. He's undergone 22 anti-VEGF injections so far, which included all the anti-VEGF molecules except Avastin, the bevacizumab, because one injection of bevacizumab made the SRF worse, so we didn't consider. And he's undergone 2 PDTs, underwent ICG before the PDTs. But there was a persistent CNVM with a slow increase in the PED, which worsened in the last 1.5 years to 2 years. Height, number, and the SRF increased, and he never dried up in the last 7 years. So this is in 2013. You can make out that there's a large PED. There's a fundus fluorescein angiography. The ICG shows probably 2 polyps here. And this is almost the clinical picture which kind of persisted over the next following ICGs also, which I did before the PDTs. This is the right eye. FFA shows a window defect. There's ISOS defect corresponding to that area. I never had a problem in the right eye since 7 years. Fast forward to 2019. This is the clinical picture. And this is after my first injection of brolucizumab. So summarizing, this is in 2019 where he was taking ranibizumab. Then had 20, I had switched over to aflibercept because he was worsening. And 2020 December is when I gave my first injection of brolucizumab, and within 2 months he started to get a very good response. So I just want to show this in a form of a video where this is the baseline, and top you see the after 2 injections. So you can make out that the large PEDs, which were multilobulated, came down. The lake of SRF dried up very well. Persistence of the choroidal cleft and the sub-RP fluid and PEDs are still there, but they came down in height significantly. So this is the OCTA. You can see that the high flow vessels have started to straighten up. The majority of the arborizing vessels kind of went away and started to prune. So this is my second case. 72-year-old male has a parafoveal CNVM for a year. Probably a PCV, 6669 vision. He complains of a scotoma. And after 3 brolucizumab and 2 aflibercept, he didn't have a significant improvement. And this is after 2 injections of brolucizumab. As I said, none of my patients needed more than 2 consecutive injections as the loading doses. And I kind of quickly could go to Q8 or Q12. The intraretinal fluid came down, the hyperreflective dots went away. The PED at the PCV lesion also significantly came down. So this is the baseline OCTA picture. You can see the BNN here, which kind of started to come down. But with a gap, there was a slight recurrence of the high flow vessels that you can see. So my third case, I would like to skip. It's been described before by other speakers. Fourth case is a 75-year-old male. He had received 4 ranibizumab and 3 aflibercept before. And this I wanted to highlight within a gap of about 2 to 3 weeks. I started to notice a significant improvement in the SRF and the PED. This is after 1 injection itself. And the perception in terms of vision for the patient was extremely good. So across the entire CNVM complex and the SRF, it really goes away. So this is the OCTA, as you can see here. This is on recurrence for this patient. Subsequently, I have given 1 more injection of brolucizumab last week. You can see a polypoidal lesion here, and this is the BNN that we can see. And it will be interesting to see how this is going to behave. Fifth patient is a 72-year-old lady, has received 8 injections so far. Last ranibizumab injection was in January, and her complaint was that there was no vision improvement with the last 2 injections. So that's the reason why we switched to brolucizumab. You can make out that the SRF lake had really increased and the SREM had increased. And this was taken about 18 days after the injection. You can make out the fluid really went away completely. And since February, this patient needed injection only in the month of June. So almost for the second injection itself, you could get a Q12 kind of a picture. My last case is a 89-year-old gentleman. He had a CNVM in the left eye. This was a PCV actually. He was treated successfully with ranibizumab. He came with decreased vision in the right eye, in fact, just 10 days ago. So I would like to show that, this was taken somewhere around the 12th, and I think the subsequent OCTA was done on 17th. This is the day, I think it was on 14th, if you can notice the date there. So the fluid, everything went away, but I would like to bring your attention to the OCTA. You can see the polypoidal lesion here and the BNN there. And this was taken after about 4 to 5 days, actually, maybe even 3 days. So you can make out that the polypoidal lesion completely regressed. We see only a small hollow around it, and the BNN also completely regressing. This response is as early as 3 to 4 days. So as of now, I am choosing chronic cases, but have started to treat treatment-naive patients, which I consider are tough. What I do differently is that I do a dilated fundus evaluation post-procedure at around 1 week and at around 3 to 4 weeks for all my patients. This is something which I do, which I was not doing for my other anti-VEGF patients. I see early response as early as few days, and even the changes on the OCTA as early as few days. We can notice reduced fluid in all the compartments like IRF, subretinal fluid, sub-RP, and in all the OCT biomarkers. And of course, after Merlin, this is something that we have to keep in mind, whether the loading doses have to be mandatorily given. Intraocular inflammation and vasculitis have to be kept in mind. Thank you very much.
Thank you for showing very impressive OCT angios and complete resolutions. And I can see Dr. Mishra online now. Dr. Mishra, may I invite you to please comment on the beautiful cases shown by Dr. Natesh and to share your own experience in ARMY. Like how are you dealing with it, and are you giving treatment naive patients or only recalcitrant? You need to unmute, sir. You are muted.
Thank you, ma'am, for inviting me. In fact, I have in my hospital, in Army Hospital, RNR, we have given more than 20 injections of Pagenex now. And the response we have given not only to the treatment naive, in fact, we have started our study with treatment naive patients. We have given around 18 odd treatment naive patients, and to 3 to the failed cases, all those who are not responders to other anti-VEGFs. We have given 2 loading doses to each of these patients and have been weekly following them. And then we have seen that up to 6 weeks, they do not require any further injections. So the response has been very good in all these cases, in all types of fluids, that is, even up to the sub-RP fluids, has shown a very good response with the disappearance of the new vessels. So it's definitely, and we have not seen any case of any intraocular inflammation in any of our cases. So we have filed up for a study to register one of our students for this study. So we'll be getting a approval for doing the study in our hospital.
Now coming to the question that we left in between that Raja was putting up, and this is to the other panelists, Dr. Giridhar and Dr. Praveen, Dr. Dipendra. Would you consider not giving the loading doses at all and start with PRN right from day one? What will be, Praveen, your approach for a treatment naive patient or for recalcitrant patient?
I think for a treatment naive patient, I would definitely try to see the patient, follow up the patient more frequently. And if at month 1 or 4 weeks, if I'm doing the OCT and it is not showing any increase and it's steadily decreasing, the fluid is decreasing, and maybe we can repeat it at 5 weeks and 6 weeks. So you can begin giving these injections to local patients who can come back for a follow-up, because we need to understand. So if there is steadily the condition remaining stable, I would like to go in for a 2-monthly loading dose, if at all, and or maybe PRN from day one also. And especially as you correctly mentioned, ma'am, that in presence of an advisory from the company itself, if something does go wrong before 2 months, then it will become difficult for us to defend also. So if the patient is worsening, then definitely we have something on our side that the patient was losing vision or worsening, then we have to give. But if the patient remains stable at 4 weeks, you can definitely extend your time of next injection.
Thank you. I can see Raja back, so Raja can now take over.
No, I think you can continue, but I missed the in between. But I don't know if this question has been taken up. I want to ask the panelists or even any of the speakers who have, if anybody has experienced inflammation in their cases. I know some mild inflammation, definitely some of us have experienced. I have one case where I have experienced severe inflammation. But the thing is that once you experience inflammation, and these patients can have recurrence of the disease itself. So once the disease comes back, in my case it's macular degeneration, I have not been able to give brolucizumab again. I don't want to, it's been a discussion off and on. But the problem is that this patient was already resistant to all other anti-VEGF. She was not responding to anything. And we have seen Dr. Goyal had also shown patients, or Dr. Ashish Vaidya has shown patients who are not responding to anything, they respond very well. But then if there is inflammation, you can't give brolucizumab again. So what choice do you have? I mean, I've tried even including Monadex.
So Dr. Narayan, regarding your case in which there was inflammation, do you think it was a low-grade endophthalmitis, or do you think it was just a pure non-infective inflammation?
So in my case, the belief is that having done from our side all possible clinical investigations, including PCR and routine grams and culture, the way the patient responded in 3 days, the entire inflammation vanished. We could see the nice fundus. Everything was on just topical steroids.
Without antibiotics?
We did. We had to rule out endophthalmitis. So we gave intravitreal antibiotic during the intervention.
So we cannot rule out that it was a low-grade infection and not really a non-sterile inflammation like a TAS,
So the point is that we have, as I said, we did everything, and the response to end of usually is not like this. In 3 days, completely vanishes. There was no lid edema, no chemosis, and we showed to Dr. Phil Rosenfeld also. And when I started presenting that case, he did not even listen to me. Immediately said, "This is how the inflammation is seen with brolucizumab." So that was his first statement, even without listening to my microbiology and everything. But yeah, we still believe it was inflammation. But the point is that the patient has again gone back to Eylea, and she's not responding at all. So I wanted to know the opinion of the panelists. If you have had inflammation, what do you do?
Can I make a comment?
Yes,
I think
half a minute.
Sure.
Yeah. So I have about an experience of about 20 to 25 odd cases, and there are equal number of patients with loading dose and PRNs. I have not experienced inflammation so far. And what I think is, inflammation is of course a function of the molecule, but it seems to be more of a function of cumulative drug, more giving monthly, because even the Merlin trial, which showed almost monthly injections over a 12-month period, I think the advisory came after that particular trial. So I think somewhere we have to strike a balance where we are giving a monthly, loading of 3 injections and then shifting to Q8 or Q12. Because, if you don't hit the disease hard first, and then you're going to give equal average number of injections in the long run, then I think you're back to square one, right?
Very well said. Yeah, that's true.
Yeah, Dr. Raja, I'll make a point here on this post-inflammation. What should be the strategy? I think 2 things. One is we have experienced inflammation, especially vitritis, with other anti-VEGF injections also. And sometimes you land up with end-off, and these patients regress. If there is a need for anti-VEGF, whether it is CNBM coming back or SRF, you have to again decide on the merit that whether it requires an injection or not. But it might be prudent to change anti-VEGF, because sometimes one episode of inflammation can change the behavior of CNVM. So it may be worth giving your previous anti-VEGF a try. But if it is not working and you didn't land up into an arterial occlusion, you can still reconsider starting brolucizumab. In fact, a certain great proportion of patients in the Hawk and Harrier trial also, they completed their trial despite getting intraocular inflammation. So,
You're
and
right, Dr. Dipina. In fact, I have had patients with mild vitritis, two of them, and still I gave a break and still continue with brolucizumab.
Raja, if I might add,
Yeah, sure.
you know, just if you're pushed towards wall and nothing else is working, I would do laser flare meter. If the reading is less than 50 under the cover of topical steroids, I will inject. And be ready, like monitor on 200 ultra wide field. And the earliest evidence of anything happening, probably go on oral steroids. I mean, it's not my experience, but this is what I would do.
Yeah. Since my patient is the mother of a retina specialist, we have discussed this and they are also not ready. But
yeah. So that's what I was probably going to add. The patient is your best friend.
Yeah.
If the patient is a mother of a doctor, then what better than that? She will understand everything. So if she's with you, you go ahead with brolucizumab. If she's not with you, just give aflibercept. That's all. I think you will have no choice. If she's not with you, if the patient is not with you, then you cannot do anything else. Then you have to play safe.
They are just losing the central vision. They are still able to move around.
Yeah.
But if they develop arterial occlusion, they will lose the peripheral vision also, and they will not forgive you. So it has to come from there.
No,
So
the way I would look at it is, hardly any cases have been reported with 3 milligram of brolucizumab and 1.5 to 2 monthly dosing. And whatever cases they may be, we have to look at them very strictly from the point of view that it may be low-grade endophthalmitis. So therefore, my take is, if we are treating the patient early, when we know that the VEGF load is not too high, okay, I'm not talking about, let's say, branch vein occlusion. Now that's a very high VEGF load versus an ARMD, which you have caught at the very early stage. Now at that stage, even a 3 milligram dosing, even at 1.5 to 2 monthly interval, would work very well. So I would recommend that we treat this drug as a very powerful drug and use as less as possible. That's what my experience with the drug has been.
Yeah, definitely more data. Definitely we should look at it. I just had one question to Subhendu, if because we are running out of time. Also, one last point. I don't know if this was discussed. His experience with PCV. Has he seen any polyp regression with brolucizumab?
I think a lot of cases were shown like that, right? Which did show the response in PCV.
I think one of his first case was the subfoveal polyp, which definitely did quite well after the injection.
No, but the ICG I haven't seen.
ICG, it was not there. From OCT, it looked like a thumb-like PED, which was probably a subfoveal polyp.
And its lack of response to other treatments also.
Raja, OCTA may not be as great as ICG to pick up polypoidal lesions.
Absolutely.
But I have noticed on OCTA, I showed one case also where a suspected polypoid lesion regressing within a couple of days actually.
OCT is better than OCTA for polyps.
Yeah. Combined OCTA and OCT picture probably can substantiate a diagnosis of polyps better. Yeah.
I fully agree with you, especially once we do the
BNN going away very well. I don't think. We have seen many cases where the BNN regressing on OCTs.
I think we have run out of time. Unfortunately, we have had a very good discussion. Nice bouquet of cases from everyone, and also very nice panel discussion. So thank you all for this wonderful meeting. You all enjoyed it.
Thank you.
See you again later. Have a good evening. Thank you very much.
Thank you.
Thank you very much.
Thank you.
Bye-bye.
Bye-bye.